ask you some questions. Okay. So, just really briefly, tell us about your journey establishing the pain program and sort of how regional anesthesia has fit into that, and it's kind of maybe drill down a little bit into point of care ultrasound and how that fits into the whole.
Sure. So maybe it's best to start from the beginning. So when I took my first job at University of California, San Diego, this is back in 2004, I think that we were already starting to see some of the growth of ambulatory surgery. So some of the previous surgeries that used to have overnight admission, like shoulder surgery, foot and ankle surgery, even hand and distal upper extremity surgery, those surgeries were starting to become routine outpatient surgeries, and so the expectation, I think, for a lot of those patients was that they would come to surgery centers and hospitals, have their procedures, and then go accompanied by a caretaker back home. And I think the need for regional anesthesia, I think that point really had to do with making, I think, the postoperative recovery, the comfort level, and I think that the level of care and dependence on a caretaker better for a lot of those patients who had to go home the same day after surgery. That demand for regional anesthesia, although regional anesthesia wasn't new at that time, this was the early 2000s, I think needed to be efficient. And so, for our own practice, when I was just starting out, I was a new faculty member, actually the only junior faculty member at that point who had not trained at UCSD. I happened to be the new guy who was doing everything a little bit different, but I think that the ability to introduce nerve blocks for those patients really paid big dividends in terms of helping them achieve not just the comfort level that they needed after surgery, but even avoid general anesthesia and go home quickly after surgery, and also be easy to take care of for their family members and friends. And so the demand actually for ultrasound grew for me mostly based on articles that I had read as a pediatric anesthesia fellow. I was very interested in the concept of using ultrasound to make nerve blocks safer, since most of my patients at that time were under general anesthesia because they were children. And so I think the interest, in using ultrasound grew from there. And there were some studies that were emerging, Peter Marhofer's group from Austria, Vincent Chan's group in Toronto, showing that the use of ultrasound helps us see nerves. And I think that the concept of being able to locate the nerve and safely place a needle and inject local anesthetic and know that the nerve is bathed in local anesthetic and can achieve a block for a patient quickly is really very appealing. Now, of course, anatomy is anatomy, and so all of the techniques that I learned that were without imaging, so using POPs and using paresthesia seeking and doing perivascular approaches and nerve stimulation, all of those are very successful also. But I think that one appeal that ultrasound had for me was really in the form of reproducibility. Reproducibility and being able to teach it. And so I think being able to visualize a nerve and being able to show a trainee that this is what a nerve looks like, and being able to help guide that needle placement in a way that was somewhat less nuanced than the old blind techniques that I learned, really made it an efficient practice. And I didn't have to worry as much as I used to about will the block set up in time, because being able to confirm the local anesthetic area and being able to look at the spread of the local anesthetic was really reassuring.
So you talked a bit about teaching the method. So going a little off track here to that. So what's it like to teach it to, say, established anesthesiologists, and what is their willingness to learn and go and do something different than the prescribing opioids and so forth? What is your experience in a sense, evangelizing for this, and also helping people to, in a curriculum, however you design that, to get them on board and get them trained?
I think that we've seen a big change, and early in the mid-2000s, I think that there was some resistance to learning something new, because at that point, most of us in practice, including myself, were not trained in using ultrasound for regional anesthesia. And I think because of that, we had very select locations around the country in private practice and in academics, that really specialized in the practice of nerve blockade. And these tended to be places that had true artists in regional anesthesia, people who really were self-trained or dedicated or mentored by other artists in regional anesthesia. But I think that over time, and I think part of it has to do with the growth of ambulatory surgery, we've needed to find other ways to provide anesthesia for patients that was hopefully more efficient, hopefully safer, and also facilitated that transition to home. And that's where regional anesthesia, I think, has really increased in terms of demand. Because of that, as I mentioned, there's a large cohort of anesthesiologists in practice who did not train in the era of ultrasound, or it was just barely introduced with fairly low-resolution technology for central venous access. Those anesthesiologists now interested in regional anesthesia have to learn. And I think that my experience has generally been favorable in the sense that when we host workshops for our national societies, we still, to this day, get a lot of people who sign up who are genuinely interested, and they're genuinely interested in trying to take care of their patients better. I think they're open to the idea. We've actually been able to study this for ourselves. We've done a number of research studies evaluating the training efficiency of learning ultrasound, and we can show that even for an advanced technique, for example, for continuous nerve blocks, placing a perineural catheter next to a nerve, if you teach it using ultrasound, even if you have an anesthesiologist who's been in practice for 10 years or more, who didn't learn ultrasound as a trainee, that person can come in off the street and we can teach them how to do our advanced nerve block catheter technique in 8 hours. And it's impressive. Now, that doesn't always mean that all of those participants go back to their hospitals and implement programs, because I think what we're starting to find is that it's not always the lack of knowledge that is the hurdle for people to change their practice. And unfortunately, until we can overcome all of the different hurdles, we can't really move the needle on patient care. But training, I think, is actually the easiest thing. I think we have a lot of anesthesiologists who truly want to show that their practice is open to changing, and regional anesthesia, we know, provides value. It provides value in terms of anesthetic care, in terms of the patient's response to surgery. It may have some benefits in terms of curbing inflammation. We know it has great pain management efficacy. And we know that overall the quality of recovery is better. And so I don't think the training is the problem. And I don't think that the enthusiasm for anesthesiologists is the problem either. I think that there are a lot of other factors.
So you had talked about recovery. And one of the things that stood out to me about the article and other things that I've read is that this could affect, patient flow, length of stay, patient satisfaction scores. It could, I don't know that it could, necessarily stop opioid addiction down the road, but you're not having to administer those drugs. But things like length of stay and HCAP scores and so forth, those were mentioned in the article. Could you comment on those other benefits and maybe some of the economic benefits also? Sure, definitely. I think that's a great observation. And I think probably the way that I look at healthcare and surgical care in general is there is definitely an underlying theme that goes along with recovery, and a lot of it has to do with preparation before surgery. We tend to focus on the in-hospital care or the inpatient stay, so there are a lot of great articles and great studies that really focus on inpatient pathways. And then there's the post-operative recovery, and I think that a common theme for all of those phases is really pain. And so what we've learned is that we have patients who, as our population ages and as obesity becomes a greater problem for our patients in terms of prevalence, we know that there are different ways that we can prepare patients for surgery that may have better outcomes. And I think the pain management problem, the opioid epidemic that I think we're all very aware of, has unfortunate ramifications for postoperative recovery. We know that patients on chronic opioids tend to have higher resource utilization during the hospital stay. They tend to stay a little bit longer. They tend to have
tougher recoveries, tougher rehabilitation pathways, and they may come back, and their risk of readmission is higher because for pain or for other reasons. And so I think being able to target those patients ahead of time to prepare them and really partner with our surgeons in that way, so that way not all of the responsibility for getting patients ready for surgery falls on the surgeons. So we as anesthesiologists, we see how the body reacts to stress. We see how the body reacts to medications every single day. And I think because of that, we have expertise that can be very useful in this area. Now, with regional anesthesia, I think that there are a number of ways that I think that we tend to incorporate this into our clinical pathways that make a big difference. One, of course, is fairly obvious, is that by understanding surgery, by understanding pain trajectory, so what a patient's experience is like for different types of surgeries, I think we can come up with clinical pathways that use a multimodal approach, which is multiple different approaches to pain management, which include regional anesthesia or nerve blocks, in order to facilitate the patient's recovery from surgery. Now, that means that we need to understand how surgery works, where does it occur, where are the different nerves and where do they innervate. I think that's also very important. So I think that understanding that and really not taking all of our patients as being the same, but understanding that every patient, every type of surgery and surgical practice is different, I think is very important. And so we may tailor approaches, specific types of nerve block techniques or other regional anesthetic techniques around the neuraxis in order to facilitate that recovery for patients. And by doing that, I think that we create these pathways that, when adhered to, can actually have some real benefits in terms of streamlining postoperative care. Now, it's not all about pain management, of course. I think that when we look at good protocols, strong protocols that actually decrease length of stay for patients, they tend to have other factors. So, for example, our own clinical pathway, while it features the use of multimodal analgesia and the use of continuous nerve blocks, we also have regular twice-daily physical therapy. We have great engagement with our nursing staff. We have great communication with our surgeons, with our pharmacists, and with our physical therapists, occupational therapists, and case managers, so that way we're always planning for where the patient is going to go next. And I think that's really important. And I think that in the end, and probably the most important thing I should have said first, was really that the patient is in the center. And so being able to prepare the patient ahead of time to know what to expect after surgery and beyond, I think is really key. And to have this ongoing conversation as the patients meet or don't meet milestones really helps to coordinate when the patient goes home. And so I think if you're able to do that, then I think that there are definitely length of stay benefits. Going to your other question about patient satisfaction and HCAHPS, we know that the HCAHPS survey is administered to all, to a sampling of all Medicare and Medicaid patients who have inpatient stays. We know that there are questions that are very specific, directly or indirectly to pain management. Now in 2018, we'll see some new questions come out because I think that some of the questions in the first version of the survey were perhaps a little bit loaded, but I think the next version will focus more on pain management, communication, and expectations, and I think that'll be a good thing. So much of what our patients experience, I think, has a lot to do with the way that we set and meet expectations. And so, for example, if you're having a knee replacement, then the expectation should not be set that you're going to be pain-free right after surgery. It also should be set that having your knee replacement is just the first step in a multi-step process to getting back, back in action, to get back to hopefully achieving the goals that patients set for themselves. And so, so one of the most important conversations that we have for patients is, what do you plan to do? And where do you see yourself in a year? We're planning ahead for, hopefully, what will be a partnership, working with the patient, working with all of our healthcare team to get the patient where he or she needs to be to achieve those goals.
So, so you've seen the evolution of the ultrasound technology that has enabled this visualization. Where have you seen it come from? How long have you been able to really, in an assured way, really visualize that nerve and really use this so that there's not a lot of variability and there's precision? So where have you come from? Where are you now? Where do you think it's going?
Mm-hmm.
And also, what do you think some of the other applications of point-of ultrasound are going to be in your practice area?
Yeah, so ultrasound has come a long way. So I think that, at least I can speak for anesthesiologists, and I could say that the use of ultrasound in anesthesiology and perioperative medicine has primarily been focused on, at first, echocardiography, so transesophageal echocardiography, especially during cardiac surgery cases, and even for some of our other non-cardiac cases, but for patients with cardiovascular disease, has been important for us in order to provide real-time information to help us guide decision-making during surgery and even after surgery in the intensive care unit. In addition, I think that I've seen during my training the advent of portable ultrasound technology, fairly low resolution, that we were able to use for central venous access. And the importance, I think, of using that ultrasound in order to demonstrate for us the safety of not only correctly placing a central venous catheter into the correct location, but also avoiding all of the different potential side effects and sometimes very in some ways life-threatening complications that can be associated with central venous cannulation. And so, exactly, pneumothorax and arterial puncture, inadvertent arterial puncture, hematoma. And so I think that ultrasound has grown from there. I remember when I first started my practice in San Diego, I had read some interesting articles from Andy Gray, who just works up the road at San Francisco General Hospital at UCSF. One of my former colleagues at UC San Diego, Nav Sandhu, Peter Marhofer, Vincent Chan, and their groups that really described early on, in the late 90s, early 2000s, what peripheral nerves look like under ultrasound. And over time, I've seen the technology evolve quickly, and it's become not just better image quality in terms of greater resolution, more features, but also much more compact. And so I think that right now, I think we've emerged in many ways, I think a new standard for image guidance for regional anesthesia, in which it's relatively lower cost than it used to be to have portable ultrasound technology that is of sufficient resolution, that identifying a nerve and also the relevant anatomy surrounding the nerve is expected. And I think that that's actually allowed us to incorporate ultrasound into training programs for regional anesthesia, not just for our residents, but also for our practicing physicians, practicing anesthesiologists who want to learn now. And so that's a good place for us. But I think we're getting close to the next step. Where do we go next? And I think, and that's where I think it's interesting. We talked earlier just about how different people are in terms of their training, and we see all comers. We have the residents at all of their different stages. First, second, third year. We have fellows now. Now that regional anesthesiology and acute pain medicine is an accredited fellowship, we have practicing anesthesiologists of all ages who are interested in learning. And I think more and more we realize, which maybe is obvious, but now is well proven, that people learn differently. And I think that there are different ways that new technology is helping to assist some of our anesthesiologists who are learning regional anesthesia, whether it's guidance systems or on the other end, looking at echogenic technology for some of the needles and catheters that we use to help aid the practitioner in training or out of training who is trying to learn how to do ultrasound-guided regional anesthesia safely. But what's also very helpful is I think that we're supported by data. And we have now a huge international registry that was started by Michael Barrington in Melbourne, Australia, that has now shown, is proven in one of his articles in Regional Anesthesia and Pain Medicine, that ultrasound decreases the association with local anesthetic systemic toxicity. So that's strong evidence. That's evidence that ultrasound improves patient safety. And so I think we can confidently say that ultrasound, I think, is now not just essential for training in regional anesthesia, but because of the availability of ultrasound technology compared to what it used to be, it's expected that those who regularly practice regional anesthesia, especially advanced regional anesthesia for some of these more complicated procedures, that ultrasound should be available.
Actually, we should talk about whether or not you want to do an article in Patient Safety and Quality Healthcare magazine. I think that would be interesting.
Yeah.
Possibility.
I think it'd be great. I'd be interested in doing that.
Yeah. Okay, we'll talk later. So your program here is, if you will, a beta test among the VA, you know, the VA universe. And so you guys are sort of like the poster children. And so you've done some comparisons with some of your outcomes and length of stay and other things compared to the rest of the VA. And because of the nerve block, it's been, and the regional anesthesia, you've been more efficient, you've had higher, I think, HCAP scores. I'm not sure if you've measured everything, but so now you've got your, you know, stake in the sand, and are you evangelizing to the rest of the VA? How's this going? If you could sort of like, you know, talk a little bit about the program in brief and how it's being evaluated potentially among your colleagues at the VA.
Yeah, definitely. I would say that our experience has been very positive, and I think being affiliated with Stanford is definitely a benefit. You know, we have, you know, where we live and who we work with, I think, make a big difference in terms of influencing what we have is what I would call a spirit of innovation. I think that one of the things that's very important about being a VA physician, that's important to me personally, and I think is very important to me operationally, is that our mission is always very clear. You know, every time I walk into the hospital, I know that, you know, the mission of the VA healthcare system is to serve the veteran. You know, we uphold and we want to promote veteran health and well-being. It's part of our VA mission. And so it's not to make more money, you know, because you could argue that government-run healthcare doesn't pay more than everyone else. So, so what you do when you come in every day is it's very focused. And I think that part of understanding and really internalizing that mission really helps you look at, you know, well, what is going to make healthcare better? You know, what is going to help our patients recover faster, and what makes sense? And I think that is a common thread that connects all of the people that work here, and I think that makes a huge difference. So for example, if you, on a Wednesday, yesterday, if you were to walk on our surgical ward around 10 a.m., you would see a huge multidisciplinary team that has anesthesiologists, surgeons, nurses, physical therapists, case manager, going to every single patient's bedside, you know, who has had orthopedic surgery. It's part of our system. It didn't happen overnight, but it's part of our culture. And I think that's important because I think when we introduce something that makes sense, in this case, you know, when we introduced continuous regional anesthesia, you know, for patients having joint replacement, we talked to our surgeons. They agreed that it made sense. They agreed that pain management was a problem. And they also agreed that pain management, when done very well, can help facilitate rehabilitation. And so there wasn't as much of a hurdle in terms of trying to implement that system. Now, I think that the same obstacles we face on the day of surgery face everyone else, which is making sure that we're efficient. And so some of the things that we really had to do, you know, in the beginning included trying to focus on how to best set up that system that guarantees that what we do can be done efficiently, so that way it's a non-issue when it comes to patient care. So many times I think that when we try to introduce new techniques or new strategies for perioperative care or pain management, they derail the system. And you introduce being a teaching hospital and trying to teach the next generation, and there's a whole nother level of potential inefficiency. We tend to emphasize efficiency. And so by doing that, by standardizing the way that we perform our nerve block procedures, you know, at this place, for example, you know, we do use ultrasound for all of our nerve blocks. That has allowed us, and some of the studies that we've done over the years have shown that using ultrasound compared to using nerve stimulation alone improves the time that it takes to actually perform advanced regional anesthesia techniques like catheter placement. So by using ultrasound, by standardizing our equipment, by standardizing our technique for every patient, so that way all of our regional anesthesiologists do it the same way, it becomes a non-issue. It takes the same amount of time every time. And by doing that, it becomes as routine for our patients, you know, who are having various types of surgeries like knee replacement and others. It becomes like having an IV placed. It's just not the most important thing that we do every day, but it happens for everyone. And then we're able to focus on other things, you know, like how do we best care for the patient after surgery? And so certain things like, I think when you get past, you know, the initial introduction of a new approach, then And as I mentioned, it becomes something that becomes expected, then there's an interesting ripple effect. Surgeons start to expect it. The surgeons start to tell the patients about it. So that way even the conversation that we have with the patient about the nerve block becomes very short. I ask them, do you have any questions about the nerve block that we're going to do for you today? And they say no. And then all of a sudden, you can actually start doing your procedure. And so it becomes much more efficient before surgery, which is great. But we also get a chance to do more things than just do nerve blocks. And I think that more and more when our fellows rotate, I tell them that my goal is really to make doing a nerve block procedure as uninteresting as possible for you, so that way you can focus on being a doctor. And once that's done, now we take the medication history for the patient. We find out which medications make the most sense. We try to maximize our use of non-opioid medications. And we as anesthesiologists not only prescribe it in the hospital, but we also manage it, and we're the first ones that the nurses call when the patients need help with pain management. So we actually have a true co-management system now here, which is very different than my first practice when I was in San Diego. That was purely consultative. And I have to say that co-managing patients after surgery has its own responsibility, but it's very, very gratifying. To actually have patients who know that, that when I come, that I'm the pain doctor and they have a surgery doctor and we work together. And I think that's incredibly satisfying. And we call that our perioperative surgical home. And it's a model that the American Society of Anesthesiologists has supported and has described in a number of ways. And not all surgical homes are the same. And so our surgical home won't be the same as another institution's surgical home. But I think that the idea of it, the idea of coordinating care, of really promoting physician leaders, physician anesthesiologists who can actively take part in patient care makes sense. Because, as I mentioned before, we understand patient physiology, human reactions to stress better than any other doctors. And so why not use those skills outside the operating room?
Great, great. This is wonderful. I mean, it's so seamless, what you're saying. It's wonderful. So you had mentioned the leadership, right? And in the article, I remember, because we wrote it, is you talked about a number of success factors. Some of those are marshaling your resources properly,
right.
Understanding who your customers are, the surgeons and the patients,
right.
and so forth. I think we took through 4 of them. In fact, I wrote them down. Identify your customers, review and rate programs, economic benefits, evaluate your resources, and leadership from the bottom up, top down, bottom and top. Could you just really briefly kind of maybe bullet point some of those success factors that you've identified and followed in implementing this program, just sort of relatively briefly?
Sure. So I think we could start with just trying to assess your customer expectations. So I think that while sometimes we talk about healthcare as being a business, that's not always a positive comparison, of course. But I do think that as a physician, I think that I have a number of customers. The first and foremost is the patient, but I also work with a lot of other colleagues that refer patients to us or that request consultation for expert opinion. And those are our surgeons, or they may be even like our primary care physicians or palliative care physicians, people who need help and advice in areas that we as anesthesiologists have expertise. But I also have other customers, like no matter high up you move in terms of the administrative ladder, you still have a boss. So I have my boss has a boss's boss. And so your hospital administrators are also very important. I think that one of the biggest issues, probably most of the most important issues to tackle up front, is identifying problems. And you never want to invest a lot of resources in solving non-problems because, for one, they may not be seen as very important. And so what I like to do, and I think what's very important for us as a group, is we routinely see our patients after surgery. We see them the day after surgery, sometimes more days after surgery, so we can assess what their experience is like after they have surgery and after they've recovered from anesthesia. We call our patients at home after they've had a nerve block, and we follow them until their block resolves so we can find out what was the experience like. And I think that trying to assess a problem from the patient perspective is very powerful. As I mentioned, I work at a VA hospital, and so being able to promote veteran health and well-being is our mission. And so if the veteran speaks, then I know that this is something I need to really focus on. And I can take that to my administrators, and I can ask for resources if it's going to address an issue that comes from the veteran. Now, in addition, I work with surgeons, and so yeah, I've worked with surgeons my whole career, and my father's a surgeon, so yeah, I'm used to working with surgeons. I think that they're important too, because I think that they have an incredible investment in the outcome of the surgery for their patients. They develop these relationships with patients over weeks to months, even years, especially for some of their patients that have long-standing disease. We need to know, what their issues are, what their difficulties are, and find ways to help them. Because I think that we, as anesthesiologists, receive our referrals from surgeons and other physicians. And by knowing what their needs are and what their issues are, then we can find a problem to solve. And sometimes, I'll give you a real-life example. So sometimes, when you introduce regional anesthesia in a new location, there's always the concern about efficiency. Well, you know that going in. So, so you should anticipate and plan the most efficient way to deliver that system. Otherwise, the patients will not get it. And I think that's important, because I think that there's sometimes the obstacles that we present are in some ways self-presented. And so if you can't deliver a new service as efficiently as possible, so that way you can make sure that the planned cases of the day start on time and will continue to be on time, and you can finish those last cases before your OR staff need to take overtime, then you can achieve your goal and you can further the patient care. But that's important. And then as far as resources go, I think that there's sometimes there's an assumption that you need to hire a lot of people, you need to bring in a lot of extra equipment, but that's not always the case. It really depends on the scope of your initiative. And so in some ways you may have a lot of resources, which is why I think that every new program, whether it's an acute pain service or a surgical home, I think is going to be different at every place. It's important to know what you already have first. So you may have some things and some people that actually are very useful. You may have people with special skill sets, people who've done regional anesthesia fellowship. You may have people in your group that have some business training that can actually help you develop a business plan that you can present to administrators. And I think that actually good citizenship within a hospital is, anecdotally, I think one of the better predictors for success in terms of implementing new programs. You may not have a focused regional anesthesia and acute pain service or a block room and any of those things, but you may have a former chief of staff from your group. You may have some of your anesthesiologists may have chaired major hospital committees, and by doing that, by having good citizenship, they have connections and they know how the hospital works. And they can help you, as you're getting your new program off the ground by pointing you in the right direction. And I think that that's really important. I think you can't discount the value of good citizenship in terms of helping to transform care and helping to further your own plans and initiatives for patients.
Great. Wonderful. Jody had a couple of questions for you. We already talked about the expanded role of point-of-care ultrasound and the other applications. I think we also, well, I'll ask the question anyway, just to be more specific. What part does ultrasound play in enhanced recovery after surgery in general? I mean, if you could make a, a very terse, compact statement about it. Yeah.
So in terms of enhanced recovery, so here in the United States, the American Society of Anesthesiologists promotes the perioperative surgical home model. Over in Europe, we hear more about enhanced recovery after surgery, and they're fairly similar in terms of their goals. Enhanced recovery more globally, if you talk about other how people have really implemented protocols that focus on enhanced recovery, they tend to be very, many ways, comprehensive, and they include everything that it takes to get the patient from preparation to surgery to full convalescence. And that means that preparing patients for surgery ahead of time, that includes the in-hospital clinical pathways that we put in place, and then the post-operative recovery. I think that we have various aspects of our practice that touch every part of that epic. Ultrasound plays a role in different phases, and so, for example, I think that we know that for some of our patients, the level of comorbidity, the level of illness and chronic disease keeps increasing, and so being able to prepare those patients ahead of time for surgery, I think, is going to be important now and into the future. Even though surgery and surgical techniques get less and less invasive, we know that the body's response to stress may not be that different than major surgery. And so for patients with cardiac disease, I think that being able to have baseline cardiac function, which employs ultrasound, I think is important. I think being able to assess the patient on the day of surgery with point-of-care ultrasound to compare that to previous studies, I think is also important. And also with our current fasting guidelines, I think that we're able to assess patients' gastric volume using point-of-care ultrasound. While it's not perfect yet, we can at least tell. While I think that that it's not ready to undo our current fasting guidelines that come out from the ASA, I think it can be a useful tool to at least help us when we suspect that a patient's stomach is full. We can at least confirm it. We may not be able to demonstrate conclusively that the stomach is empty, but when something is in there, when we see fluid and we see food, we can at least say that the stomach is full, and that affects our decision making when it comes to managing the patient's airway and intraoperative course. We also can use point-of-care ultrasound during surgery by assessing fluid status, by looking at contractility of the heart. We can also we can use it for lung assessment, which also is very helpful during and also after surgery, when patients sometimes have difficulty breathing. And I think that that's going to carry through. And then, of course, for some of our patients, one of the big risks that we are concerned about, especially in lower extremity joint replacement, is deep venous thrombosis. And so the ability to use ultrasound to help detect the location of a clot when present, I think, is also very important. And in terms of our patient population, because we do have a surgical home model at our hospital, we do find that the utility and availability of ultrasound equipment is very helpful because it takes some of the guessing out of assessing patients. It is, and in many ways, continues to increase as far as availability and prevalence as essentially the replacement of our stethoscopes. So I think that that's only going to grow. And we see this even in the medical school curricula. They keep changing, and medical students are now learning to use ultrasound as part of their study of anatomy and in their clinical rotations. And so I think that our trainees, as they come up, may have more ultrasound experience than some of us. And so I think it also behooves us to stay on top of things and try to learn it first.
That's right. Yeah, I hear a lot of that. That it's really, I mean, more and more, residents and students are really learning it. And they create pretty pictures. They're really
They do.
good at it. Yeah, yeah. So one last question for you. And this is, you've really covered it, but I think it's kind of a nuanced answer, and that is, with the growing opioid epidemic, how can nerve blocks help? Now, I know you can't cross a certain, it's not going to prevent addiction and so forth, but in terms of maybe not getting people started on opioids or whatever nuanced answer you want to give on that.
Yeah.
We'll be careful with this one. I know we need
Sure.
to.
Yeah. Well, I think that's important. I think that regional anesthesia, I think, has really been pushed to the forefront as a very powerful non-opioid analgesic. And I think it's not surprising that it comes at a time when everyone, all people worldwide, but healthcare professionals especially, are very aware about the opioid crisis that we currently face. My personal opinion with regional anesthesia and my own experience as a practitioner of regional anesthesia from the beginning of my career has been this is one way that we as anesthesiologists can provide the most targeted form of pain relief. It's as specific as a surgery. And I think that from the patient perspective, it's extremely convincing to be able to receive a nerve block with local anesthetic, a non-opioid form of pain relief, and emerge after anesthesia with no pain. I think that's actually a very powerful message in many ways. And now, whether or not it has long-term implications, we can debate the current available evidence, but I think that's very powerful from the patient perspective, to know that that one approach, that using local anesthetic can actually completely prevent their pain and even relieve their pain. Now, as far as long-term data that we have so far, we have 2 studies that recently were published in Anesthesia and Analgesia that show that our current nerve blocks that we have for shoulder and knee replacement don't prevent chronic opioid use. And now, while that sounds a little bit disappointing, I actually look at it as a challenge, because I think that right now we're just starting to learn how long pain really lasts. And so when you look at the pain trajectory for knee replacement, we're looking at in the order of days to weeks. And so until we have the ability to actually perform a regional analgesic technique that matches the trajectory of pain, then we shouldn't expect that we're going to have these long-term effects. And it also introduces other questions like, how are patients getting their opioids, and are they being prescribed for other reasons that are separate from pain? And I think that that introduces a number of other loaded questions. But I think understanding the trajectory of pain and being able to match our analgesic approach in terms of geography, in terms of region, so being able to provide a targeted pain relief modality, and also match the duration, so that way patients actually have, hopefully, as much as they can, an opioid-free recovery, is really important. And I think that regional anesthesia for right now, in our current limitations in terms of how long local anesthetics lasts, including infusions, we're able to do a good job, but I think it can be a better job. And so we still have some work to do, but I think that being able to show patients that it's possible is very powerful, and hopefully will propel us into the future in terms of research.
Great. And I actually lied. I have one question. This is actually sonosite specific, and that is, I just finished writing up an article on total cost of ownership. We were talking about the education and training piece of it, and sonosite's very heavy duty into training and so forth, which, if done, separately, would be an expensive proposition for a hospital, and maybe not so coordinated. Could you, and I don't know to what extent you've benefited from online resources that they have on site, etc. Has this been of value to you, like the training and the learning resources that they provide, learning centers and on site? Has it been valuable to you? It may not be, but if it has been, it'd be interesting to hear about it.
I could probably speak more generally just about partnering, and I think that I think we have professional partnerships, I think, with various companies, that through our professional organizations, through individuals, and also through groups, that help provide training. I think it's very important that trying to promote better patient care is always first priority, but that priority is shared by a lot of people, and I think that we need to look for the opportunities to partner in the most effective way in order to give our physicians the training they need to take care of their patients better. And so we've definitely benefited in multiple ways, and I know that companies provide training, which I think is very, very helpful for people in order to learn how to use equipment, but also learn how to take better care of their patients. But we're also very grateful to companies for providing in-kind support through equipment for a lot of our CME-based workshops and annual meetings. And that's been a fantastic partnership, because I think that not only do the attendees at those events go and learn, they can learn from the experts and try to find innovative ways to care best for their patients, but they also look at the new technology as it comes out. And I think that we all have to realize that there is a need for public and private partnership, because we're not the ones that are investing all of the money that it takes to develop a lot of these new technologies that are going to benefit our patients in the future. So I think that we will need those partnerships. I think that what we're all interested in, from the educator perspective, from the physician perspective, from the society perspective, and from the company perspective, is does the education, does it pay off? Does it actually lead to changes in healthcare for patients? Are patients getting better pain relief because we provide the education? And I don't have a great answer to that yet. One of our recent studies that actually studied some of our workshops and participants and followed them over the course of months to years to see whether they actually changed their practice was very interesting. Overall, on average, participants in our one-day workshop did increase the number of advanced nerve block procedures that they were performing. But it was very interesting that there were certain subsets of people, certain individuals, and obviously did more implementation than others. And so I think that we have a lot of work to do to figure out where is the gap between education and changing clinical practice. I think once we understand the gap, I think that we'll be able to target education more closely to, I think, helping practitioners overcome those obstacles. Because I think right now we get very focused on teaching the techniques, but when we see that there's so many other steps that it takes for physicians to go back and actually implement that change, we need to start evolving the way that we teach. And so we're not quite there yet, but I think that we could probably work together and figure it out.
Fantastic. Great.
Thank you.
Wow.